our community health profiles. Today, my name's Tessa Lindfield. I'm an Assistant Director in Public Health here at Birmingham City Council, and hopefully be steering you through the next hour as we launch the community health profiles we're going to talk about this afternoon. And this afternoon, we're concentrating on two of our new profiles for around the lesbian community and the trans community. So we're really delighted to see so many people joining us. We're not going to do a round of introductions, but if people can put in the chat who they are and the organisation they come from and any contact details, that would be really fantastic. So we'll introduce ourselves via the chat function here on Teams. And I'm going to start off straight away with a welcome from our Cabinet member, Councillor Mariam Khan.
Hello everyone, I'm Councillor Mariam Khan, the Cabinet Member for Health and Social Care. I'm delighted to see the launch of our community health profiles and so pleased to be welcoming you all. I am proud of how diverse Birmingham is and of how welcoming we are to people who choose to make this city their home. However, we know that not all of us experience the same levels of good health and well-being as each other, and that there are real differences between communities. In the Council, we take this seriously and see tackling these unfair differences in health as a core component of the work that we do. The community health profiles have identified and summarised the physical health, mental health, lifestyle, behavioural and wider determinants of health-related issues affecting communities both locally and nationally. The findings from these key public health documents will shape how we address, protect and prevent health inequalities in our city. We've always struggled with understanding the detail of some of these inequalities, and this is where our community health profiles come in. The Public Health Communities team have, in partnership, developed a series of evidence summaries that focus on helping improve our collective understanding of our diverse communities, the health and well-being challenges and key inequalities that they face. I hope that you find this session useful. We have the opportunity today to share our approach and findings with you and also to discuss this in more detail. And afterwards, we'll look towards how we can work together, not only for our respective communities, but for Birmingham as a whole. Thank you.
That's brilliant. So Councillor Khan's really sorry that she can't be here in person for the launch event today, but really happy that we managed to get that recording of her welcoming everyone to the session. So it's great. So let's move on then. We've got a little bit of housekeeping to start with. So we've got quite a few people on the webinar. It's great to see people starting to introduce themselves in the chat. So if you've just joined, please put your name and contact details in there. It's really good so that we know who we're talking to. If people can stay muted to avoid background noise during the webinar, that would be great. Sometimes we find that turning off VPNs helps if you're having any bandwidth problems, if the video is going a bit scratchy. That might help. And yes, any questions that you have, please put them in the chat. Really pleased to see them there. And the webinar will be recorded today, and we'll put it up on the City Council website so that people can watch it if they weren't able to make it to the session. Brilliant, great, more people joining, that's fantastic. We'll also be using Menti for some question and answer kind of interaction during the session over the next hour. Menti's piece of software you can download onto your phone, an app that you can download. If you haven't got it already, you could scan the QR code or go to the App Store and search for Menti or go onto the website. And the code that we'll be using for today's session is there, 41607622. We'll be coming back to that a bit later on in the presentation, so you'll have a chance to do the code and we'll pop it into the chat when we get there as well. So if people want to get themselves organised and get Menti up and running, then please do sort it out on your phone because we'll be using it a bit later on. Okay, next slide. Okay, so I'm going to start off by just giving a bit of background as to why we decided to do these community health profiles and where they fit in more generally into our public health programme across Birmingham City Council. And you'll be aware that one of the key roles that public health has is to support decision making around health and well-being, and particularly decision making around actions to tackle health inequalities. And we know that, the causes of whether we're healthy or not are varied and many, and determined by our life chances and our personal circumstances, as well as the services that we have access to. So we consider all those things in public health because they're all determinants of our health and well-being. And we also know that decisions made on services and approaches put in place to improve our health and well-being or tackle health inequalities are best done when they're based on facts. And one of the things that we do in public health is to bring back those facts about populations so that they're there to help decision makers when they're designing services and approaches to improve health and well-being and tackle health inequalities. So in public health in Birmingham, we are working on a series of evidence reports to assist decision making. Now, some of those decision reports are things we have to do by law, they're statutory. So we have to do a joint strategic needs assessment, and you'll see a description of that there, and that's available on our website. And we also, the council has to publish an independent report from the Director of Public Health each year. So Justin Varney, our Director of Public Health, does that each year, and the council publishes it. So we have to do those things. But if we go on to the next slide, in Birmingham, we've chosen to enhance that with a series of elective reports, and you'll see that we've got 3 broad categories of reports here that we're doing in addition to the statutory ones, and community health profiles are one element of the programme. And you'll see there that the differences between the different elements. So we've got commissions that we've commissioned out, deep dive needs assessments, and then our community health profiles. And the idea of the community health profiles is that they're a collation of the evidence out there around health and well-being for a particular population group, where we've done a desktop analysis of the evidence that's out there that's published, so that's reliable information, and brought it together to give us a snapshot of the health and well-being status and inequalities experienced by the particular population of interest. The next slide. So everything we do around health and well-being in public health and across the system in Birmingham is driven by our health and well-being strategy. And the aim of the strategy is for us to be a bolder and healthier city, and to become a city in which every citizen can have a healthy and enjoyable life. And the community health profiles really help us understand some of the gaps in achieving this ambition. So the gaps in health, the health inequalities between different communities. So as I've said, they describe a particular community of interest, and they might be a community that's bonded by identity or experience. There's a variety of different communities which we've chosen to include in the community health profiles programme. And as we've said before, the idea is that bringing together this information helps decision makers, and we want to make them public so that they're a resource not just for people within the council, but they're a resource for the whole system, and they will be useful for people outside Birmingham as well, so that people can use them as a bit like an encyclopedia of the information that's available around health and well-being for a particular population. Now, we're always aware that the minute we publish something, it's out of date. That's just the nature of how collecting information is. But we're keeping a live eye to new information that will come out. So, for example, we're waiting at the moment for our census data on ethnicity and all sorts of other aspects of our population, which will come out in the next few months. So it may be that that will cause us to do some updating or add some information to the profiles. And if something really major came out, then we would update the profile. But we're not looking to say we will definitely update this profile in 2 years' time or 6 years' time. We're going to have a pragmatic approach, depending on the new data that becomes available, when it's sensible to update the information in each profile. So this is our forward plan of the various types of evidence reports in the programme. So you'll see on the left-hand side there, in the pink box, we've got the community health profiles, and in bold, we've got the 2 that we're particularly talking about today. But you'll see there's quite a large kind of number of profiles there, and a broad range of communities. And we've chosen communities that are represented within Birmingham, and communities where it's possible to collect the information and produce the profile. And then you'll see the other 2 boxes talk more about the deep dive reports and the commissions. So the Poverty Truth Commission, which is running at the moment, and the Birmingham and Lewisham African Health Inequalities Review, African and Caribbean Health Inequalities Review. So you'll see there how they kind of all fit together as the overall programme. And the next slide. So the community health profiles aim to look at not just physical health and well-being, but we want to look at mental health and well-being as well, and also health behaviours and the wider determinants that exist within in a specific community. And the idea is that because this is, we're all working under the umbrella of the health and wellbeing strategy for Birmingham, our Creating Bolder, Healthier City, then we are using the priorities of the health and wellbeing boards to structure the report. So when we get to, I'll get to a slide in a minute, we'll talk a bit about themes and what's in them. You'll see that there's a common narrative that follows the structure of the health and wellbeing strategy. And we don't just want to kind of publish these and that's it, that's the end of the programme. The idea is that we want to engage with communities to share the profiles and to get feedback on them so that we can make them better. And we want to discuss the opportunities that are shown within the profiles to address some of the inequalities that are evident. And we really want to promote the use of these summaries. So, you know, I'll be really excited when I'm in a meeting and someone comes back and says, oh, did you know that? And I think that was in the community health profile. And then we'll know that people are using them and reading them and using them to make decisions. And that's really what we want, is to make sure that we're making sure that they are useful and used for decision making, because that's the purpose of them. So next slide. So each of the profiles has a set of themes. They vary a little bit between the programmes, but they are broadly around the health and wellbeing strategy. And these are the themes that are contained within the community health profile for our lesbian population. So you'll see that we go from the kind of cradle to the grave. And then we also have specific sections on closing the gaps. We talk about a green and sustainable future because the environmental concerns are such a key long-term determinant of our health. And then, of course, we're in a public health environment here, so we're still talking about COVID. But here we're talking about mitigating the legacy of COVID within the health and wellbeing profiles. So we move on to the next slide. And again, a similar list here for our trans community profile. So the way that the profiles have been done, because we want the information in the profiles to be reliable so that people are confident that the information in there is reliable and that they can use it. So you'll see that they are based on literature reviews of the academic literature, peer-reviewed literature. There are comments within the profile where the evidence is stronger or not so strong. Because there isn't a lot of information out there about some population groups, we've also gone to the grey literature, so literature that's published from community organisations, government, which has also got really useful information in. And then they've been conducted as a proper academic literature search where we've praised the quality of the evidence that's published and summarised it in a way that hopefully is useful under the theme so that people can find what they want to find the information that they're interested in and be able to present it in a useful way. And you'll see there the methodology for the trans profile is pretty similar, slightly different search engines used, but it depends on the nature of the literature you're looking for, depending on the best way to search for it. But that gives you an idea of what the process has been. Okay, moving on. So we know that the census data is just about to come out, as I mentioned earlier on. I think November we get the next tranche of information coming out. The data in the profiles that we've published now are from the 2011 census and may have changed. So we've already had some of the initial findings, and we know that the Birmingham population has changed a little bit, got a bit older actually. So therefore, we need to bear in mind that some of the census information may have shifted, and that might change some of the information in the profiles. And there are limitations in the data. We've reported the stuff that's available. You know, we haven't created new information here. So if the information isn't there, we can't put it in the profile. But we have said where there is limited evidence to inform where people, if they're looking at these profiles, to inform future research programmes where they might want to to conduct additional research. And often we've found that the existing research doesn't disaggregate findings within a particular population group that they've studied in a particular study, for example. So sometimes you'll see in the profiles that they haven't disaggregated findings, for example, between lesbians, gay men and bisexual men and women. And where that is the case, we've made that clear within the profile. But sometimes it hasn't been possible to drill right down to the particular population that we're interested in. Okay. So the community health profiles published, you'll see, if you've had a chance to have a look at the website, that there is a written report and also a PowerPoint slide deck. And it's on the Birmingham City Council Communities webpage. And the PowerPoint slide deck has a set of infographics in there. And there will also be a YouTube highlights video and also the copies of the recordings of these webinars that we're in now. So hopefully a good suite of resources there that will help these profiles be used. And we're really looking forward to seeing presentations from other people in the future where things have been cut and pasted from our slide decks or from the document. So they're there to be used and accessed by everybody who want to make them public. Okay, thank you. Next slide. Right, so I'm going to pass on to my colleague Ricky Bandel now, who's going to talk us through some of the details in the particular profiles that we're looking at today. So over to you, Ricky.
Thank you, Tessa. Hopefully everyone can hear me. I just need to inform everyone there's a little bit of a slight delay in terms of when I see the slide from what I presented. So if my head's going down, it's because I'm reading off a different screen. So just before to kind of start, the lesbian profile and the trans one, we grouped together due to the fact of that there's 16, 17 different kind of profiles that we've got to go through. And so thematically, when we've got similar stakeholders involved, we've tried to bring everybody together to try and manage time and around that. What I will say is that the links to all the profiles will be made available in the chat so people can have a look at it. And a real big thank you to the communities team. I'm just here to kind of front it within there, but it's the hard work, and Bayswater, who authored the trans profile, have done an absolutely terrific job. And you know, they will be joining us on other profiles and other pieces of work that they've done as well. So we'll put out links, and I think Priya may be in the audience in today, so a big thank you. I need to kind of give a little bit of a heads up on some information that's going to be discussed in today. There are very sensitive topics that I'm going to go through, discussing from mental health, anxiety, depression, self-harm, homophobia, hate crimes, eating disorders, transphobic hate, and you know, and other sort of very triggering kind of language within there. We have got a section at the end which is talks about some terminology also being used within there, but also kind of referral information and phone numbers, just in case if anything that come out of here, it does trigger something off. It's quite a bit nerve-wracking from my point of view in terms of talking about some of this information, because it is so very much emotive within there, and a lot of information that what we've found within here is not really nice to kind of say, but this is acting as a foundation for people who are in this audience who may want to use this profile to go and put in bids or anything, or pieces of work that they're looking to do together. And we hopefully we've tried this. We haven't said it's 100% perfect. We've made an attempt within that. Hi, Priya. And we want to work with people. And especially over the last 18 months, the importance of engagement and working with partners has come hugely. So this is a resource for everybody within there. But I just wanted to just make sure that, you know, if anybody's feeling that there are some support, and there's individuals within the chat today which will be able to do that. Is that okay? Right then. So structure of it is I'm going to go for the lesbian profile first, then the trans, and then we're going to have a bit of a Mentimeter exercise to build in some of your engagement, and then looking at next steps as well. So this presentation will be available as well to you also. Okay, so looking at the lesbian community, so one of the things that we found out via the Office of National Statistics was that there was in 2019 there was an estimated 370,000 people in the UK who identified themselves as lesbian. And that was estimated between 4 and 14,000 maybe living in Birmingham, and that again came through the Office of National Statistics. What I will be doing is when I'm going through a bit of a slide, I'll mention one or two things and then the reference for it as well, just to give it a little bit of that accreditation. The reference section in this document is very, very big. So everything that you're going to be using in your future sort of correspondence, it is all referred to. And even in this presentation that we'll make available, there is a reference to this section as well also. So younger people aged from 16 to 24 were most likely to identify themselves as lesbian and bisexual, making up the highest proportion of community in the UK. I'm going to say, Jordan, are you right to move on to the next one? I'll be saying Jordan quite a lot because that's her point where to move on to the slide. So in general, the overview of what we find within the profile was that there was higher rates of poor mental health, increased use of substance misuse and smoking and alcohol consumption, increased risk of obesity, lower rates of cervical cancer screening, and more likely to report no confidence in doctors, and finally, increased risk of eating disorders and self-harming behaviour. As Tessa had explained earlier on at the beginning, we are following the themes identified within the health and well-being strategy. So from our first basis around getting the best start in life. I'll jump to the bottom bit because this is a bit of a theme that fits out in quite a lot of the profiles that we've had, which is around perception, stigma, and around about having healthcare professionals being aware of services. So barriers to IVF, for example, doctor referrals, the lack of knowledge from doctors is big. Afraid to ask for that support from via IVF. Perceived in the stigma around homophobia, and the criteria around self-funding of what's required. Based on a study which was done by a university hospital, a total of 29,465 babies were born in Birmingham between March 2019 and October 2021, and about 0.2% of those were born from lesbian mothers. Some of the stories in terms of the statistics that I'm stating is not necessarily about what's actually being said. It's about the opportunity of engagement to make things better. So always thinking about, we don't give a list of recommendations that come out of this. It's literally what we find put together and trying to empower the community to say these are kind of starting points that might be useful to people. Jordan? Am I frozen? Okay. So for it to be continued again, so under the Stonewall school report that was published in 2017, 45% of lesbian, gay, and bi and trans people are bullied for being LGBT at school, according to the report itself. Lesbian high school students were 1.9 times likely to be more overweight compared to their heterosexual counterparts. What I would say though as well, especially within this area, and it's quite common in a lot of the profiles that we found, and echoing what I've said before, it's not necessarily what we find, but those gaps that are missing. There was limited data on childhood poverty and educational attainment for lesbian youth or children to lesbian parents. Jordan? Again, one of the areas which is quite heavy in terms of some of the our findings within here. In a report that was done by Public Health England at the time, they reported 38% higher rates of poor mental health, anxiety, and depression in lesbians compared to heterosexual women. That report was from the Improving Health and Wellbeing of Lesbian and Bisexual Women and other women who have sex with women in 2018. Two in five lesbians have experienced negative or mixed reactions from mental health care professionals. Again, this was done by the National LGBT Survey in 2017, subtitled Healthcare Amongst Lesbian and Bisexual Women. Another thing for our drugs colleagues, especially partners that we would present information to, more lesbians, 79% reported having used drugs compared to heterosexual women of about 61%. So looking at in terms of cohort of addressing some of the needs and wants from the community, is probably something that we need to look forward for in terms of engagement. Jordan? A new area which we've had in our team has been successful is our food strategy, our food team within public health, and this is where some of our work and that joint collaboration work would come together, and very topical at the moment, which is around healthy and affordable food. So around 1 in 5 sorry, my glasses. Around 1 in 5 lesbian and bisexual women have an eating disorder. That's compared to 1 in 20 heterosexual women. This was taken from Public Health England data from 2018 around improving health and well-being of lesbian and bisexual women. Lesbians are around 1.5 to 2 times more likely to be obese than heterosexual women. This was referred to in at least 3 different pieces of work that we found. One of which was taken from 2020, a report that was done by James Salnian around sexual orientation identity and in relation to unhealthy body mass index. It is worth noting at this point, again, around the research limitations, that there was limited in some areas around limited data. So what we've done in those cases where we were able to attribute it, we have credited it as well. So if it's not just in the UK where there's comparison data that's been published, we've highlighted that also. Looking at in terms of physical activity, the rates of physical activity were less than 30 minutes are low in lesbians at 21% of bisexual women, and heterosexual women at 32%. 39% of lesbian and bisexual women said they exercise on most days compared to 28% of heterosexual women. And that was taken from a 2018 study of cardiovascular disease, of disparities in sexual minority adults. And that was looking in a cohort year group of approximately 2 years, which was 2014 to 2016. I'm very conscious I'm sending out a lot of data and I'm speaking out on a lot of data. And we've summarized this in infographics, which I'll show you a little bit later on. Also, to give it some context, there is a much deeper profile which goes into a lot more detail within there. You appreciate that we're trying to give you headline data from about 500 pages worth of profile data for both groups. Jordan. Another theme which was around employment and education. So in a study that was done by Birmingham LGBT Centre, it stated that 67% of lesbians cited the highest level of qualification as degree or equivalent. Looking around in terms of some of the other data that's been established with the employment rates amongst those ranges from 15% to 17%, which is higher than heterosexual women. That was taken from the London School of Economics in a 2017 study, and also from another study that was done in 2015 by Emma Elliott around sexual minorities in England who have poor health and worse healthcare experiences, which was a national survey. Employment is obviously one of the biggest sort of public health factors that can help improve health life expectancy. Jordan. Now, the next sort of 3 or 4 slides are one of the later themes that we've added in at the time around the health and wellbeing strategy, which look at protect and detect, aging well, around closing the gaps, and then finally around COVID-19. So from protect and detect, you know, when you get an email at the wrong time, I can't see the screen, it's just happened just there and then. So lesbians are less likely to attend cancer screening, including the pap smears, when compared to heterosexual women. This was taken from a study by Justin Varney, actually, from in 2015, which was around health and well-being of Southwark LGBT network. 35% of LGBT women think that they don't need to test because of their sexuality, while 38% did not think that was important. Again, this is another sort of campaign opportunity that can be by used, and that was from a study that was done earlier this year, which was looking at gay and lesbian, bisexual women in the Northwest, and it focused on cervical screening attitudes and experiences. So then summarizing sort of the 4 areas around barriers of accessing the screening. It showed again some of the things that we discussed in the previous slides around stigma, around sexual orientation in healthcare, fear of being discriminated, negative experiences, and then the wrong perceptions. The next slide would sort of summarize a little bit around protect and detect. Again, looking at in blue, around 78% of lesbians reported never visiting a sexual health clinic. This was taken from Out and About, again from the LGBT Centre in 2011. If we go on to the kind of the last slide, sorry, in purple, sorry. That's it. Sorry, Jordan, my fault. A survey revealed that the main concern of sexual contact in lesbian community was cancer at 69%, followed by a risk of other sexually transmitted infections at 43% and HIV at 25%. This was from a government equalities office in 2017, which was a national LGBT survey. Sorry, I don't know. Is someone on mute? Okay. Going on to aging and dying well. Lesbians have been found to have high cancer, higher rates of obesity, sorry, and central adiposity, which increases the risk of developing CVD, which is vascular disease. This was taken from a report that was done in the early 2000s, in 2003, around cardiovascular disease risk in lesbian women. The prevalence of cancers is also on the other side, which was summarized quite effectively in the infographics as well. So I won't go too much into it that way. But looking at the final point, there was a study that was done by S. Westwood in 2016, looking at dementia, women and sexuality, and that looked at the issue of and discussing the term of double stigma of sexuality and dementia. And it found out that many residential care settings feature heteronormative communities. Jordan? So in terms of opportunities, in terms of looking at closing the gaps around life expectancies, experience with the healthcare sector, and communication with healthcare professionals. For women who were married with same-sex partners between 1989 and 2004, there was a risk of mortality of 34% higher than general female population. This was taken from a journal that was being done in 2009 around mortality among men and women in same-sex marriage, and it was looking at a national cohort. But for this one, there wasn't a UK population. This was actually taken from Denmark as well. Jordan? One of the latest information that's coming in and will consistently sort of updated as we are coming out of post-pandemic was the effects of COVID-19. So Stonewall in 2021 did in their Lesbian Visibility Week survey, they released some data that had come through, and within that it looked at 49 to 77% said that mental health had worsened during the pandemic. Around 50% stated that they had access services in the previous 12 months, while 12% tried but were unsuccessful. I'm conscious in terms of, as I said before, that we've mentioned quite a lot of data within that, and putting it in a more palliative kind of format. We created infographics as well, which summarized it pretty well. So Jordan, can you show there's four four infographics that we're doing. One is around the overview and the content and the international context. So looking at some of the first data that I mentioned when I kicked this off. Second one, this then refers back to the health and well-being strategy that we looked at and the themes within there around mental health and wellness, affordable food, and the getting the best start in life. All the statistics in that I've been mentioned here are all referenced and credited within the actual profile itself. It's stunning the way that the graphics have been done and been really really well appreciated. Next one, working and learning well. I won't go into some because some of it I've already mentioned within there, but it's for those people to have a look on screen while they can. And the final one is again looking at sort of the closing the act. Okay, so I'm just going to pause there for a second and bring in Tessa as well. Is there any sort of questions that have sort of popped out at this point before I go into the next profile? I just want to give it a quick opportunity for anybody for first comments or anything like that. I'm going to take silence as a good thing. Okay. All right, I'm going to go into the next one. I could have a clapping emoji or something like that. That would help. Oh, thank you. Oh, we've got somebody. Hi, Hunji.
Oh, sorry, I just want to clap. Sorry.
Okay. Okay. Is there another question?
Yeah, there's a hand up.
Okay. I can't see on my screen from there. So if it
Hang
is,
on, I'm
please.
getting there.
Okay.
Okay, I've got got a couple actually of hands up, so I've got numbers and everything. So the first one's from Jazz.
Thank you, and thank you so far for the presentation. That's great. Just a couple of things, and it might get answered at the end, so apologies if I'm jumping in too quickly. So firstly, how do you guys decide which bits of data that you use? Because invariably there's going to be lots of different things that potentially can be used. So I'm kind of worried, and I don't mean this horribly, but how do you cherry pick the bits that you do want to use? So I'm kind of just interested in that. And then I suppose the second bit, which is like the more kind of important bit, is the rationale and the explanations behind the data. So there were so many statistics that jumped out at me there, and I want to ask questions about all of them. But for example, the one about 1 in 5 lesbian women have eating disorders compared to, I think it was like 1 in 20 of heterosexual women. I kind of feel like I need to know why. Like, what are the factors? What are the barriers? What do you know what I mean? Because the data is great, and I so will use that data in my day-to-day job. I need to understand more behind it. So is that up to me to go and research it, or do you provide any kind of like links to that?
Yeah. So I'll answer your second question first, and then Tessa, are you all right to answer the first question if that's all right?
Yeah, of course, yeah.
Okay. So the second question, sorry, your question around where the links are. As you go through the profile, it's all split into different sections within there. And you could find the reference within it, even on this presentation that we can share with you. If there's any statistic that you can see from there, if you click the reference in the section, it will take you straight to that point and give you the wider context in terms of why where that study was done and where the depths on it. So we haven't come up with these ourselves. This is based on public open source data that's already been within there. And it should give you a more bit of a comprehensive kind of look. And it is one of those things where if you read this paper, it might take you to another paper to have a look on, but that gives you that holistic sort of viewpoint of what that statistic is there. Is that all right?
Yeah, I mean, I suppose I would, but without kind of adding to your guys' workload, but it would just be nice to have maybe just a few of the headlines around that without then having to go off and do all that research, because I will fall down so many rabbit holes with this research because I'm genuinely interested in it.
Yeah,
I
sure.
kind of feel like I kind of just need like a few little snippets
Yeah.
of like pertinent points. That would be really helpful just from my perspective.
Sure.
I
Tessa,
think
you all right
that's
for-
really, yeah, really happy to pick that up. So I think in the actual profiles, where that information is in the papers that have been looked at, then we will, it's included. So so I can't remember what it says about the eating disorder bit, but if there's some suggestions as to why that is the case that was in the research that was found, then that will be included to give you that heads up, because I agree, it's no
Okay.
point just presenting the numbers cold, is it?
Mm.
And that you asked about how the authors have chosen which particular data to report. And I think behind, I mean, it's enormously comprehensive, the profile in terms of a summary of the literature that's actually out there. But I think they have looked at loads more papers and rejected them if the quality wasn't good. And you'll see in some of the sections where there is multiple reports around a particular topic, it'll say something like the consensus is that such and such a feature is around, I don't know, 45% of this population. Studies report that prevalence varying from 17% to 60 or something. So they will kind of try and give you a ballpark about what all the studies say, and then an interpretation about what the range is, so that you can be confident that the number in there isn't just picked out of the sky or from one particular study. They will have looked at a range of studies in order to come up with those numbers. And if that isn't the case and the evidence is thin, because there isn't much published on it, then they'll say so in the profile as well. So I'm hoping that will give you a few clues as to the reasons behind some of the data, and also some confidence in the numbers that are reported.
Absolutely does, yeah. Thank you. And I just want to acknowledge I appreciate just how much work and research goes into this. So thank you guys for presenting it.
No problem, Jess.
No, it's fine. It's
one
good.
more.
I'm really hoping it's going to be useful. So we've got another question there. Is it I don't know which is your first name. Is it Cumby, your first name, or career word?
It is Cumby.
Hi, welcome, Cumby.
I can be.
Thank you. So I echo Jazz's thoughts. You know, it's quite comprehensive, which is quite good. You have partially answered the question, so I guess it's around getting access to this information after the sessions. Because I'm conscious you're running a number of them. So will you be sending participants the presentation, access to the links and the recordings?
Yeah, it's going to be it's literally live right now. Anyway, the profile is. We will make the presentation, the link, and upload it onto there as well as soon as this has been done. But yes, you'll be receiving correspondence within 24, 48 hours really of some of the information that's been put on here. But like I said, the profiles themselves, the bigger document, is already live on our website, which there should be a link in our chat at some point.
Yeah. And if you
That's
just put
helpful.
in community Birmingham City Council community health profiles, they'll come up, and then on that page you should have all the resources, including the link to the webinar from today, and the reference list is at the back of the profile and also will be on the slide deck from this presentation.
Amazing. Thank you so much.
That's okay.
Okay, I'm going to move on to the next. I'm obviously keeping an eye on time of that as well. At this stage. Okay, so we're looking at the trans profile next. Now, an overview of the trans community showed there was people from whose gender identity diverges from their sex at birth from oh, sorry, I can't see this at the moment. The size sex at the birth form the transgender community. So there, when we're doing the profile, there is terminology within the profile in terms of some of the language used. Also, very conscious about acronyms as well. It is very easy in terms of our kind of public health speak or academic speak that acronyms are used. So they have been explained. So an estimated 0.8% of the UK population identified themselves as transgender. This was taken from a study that had been published last year in 2021, and this was measuring gender identity, equality, and human rights commission, who'd who had done it. An estimated 536,648 trans people in the UK had also identified themselves within the same study, and just over 9,000 trans people in Birmingham. Will this change with the new census data? I'm sure it will be, and we'll have obviously more accurate figures with that, which Tessa had mentioned this at the beginning of the first profile in terms of what we will update where we can. Jordan? This area was okay. This area was a little bit more difficult to kind of do that, and credit goes to Bayswater, who we commissioned out this the profile, and there's no evidence on some aspects of trans people's health and wider determinants of health, as there was limited evidence even in other areas. So what we've done is to do the best part of information that we could do that, and that is identified in the methodology in terms of in the profile of what had been done. But ultimately, there was no robust data for trans people on health and long-term illness in the UK, and very limited in international data. That doesn't take away from anything that what we've done from here. It's the best information that we were able to pull together as well, but also then it gives us more armament when we're lobbying or pressurizing or going towards central government for monitoring and data purposes. So an overview of what we found within the profile was that there were multiple barriers of accessing trans-Pacific healthcare, higher prevalence of mental health problems, higher rates of self-reported disabilities, higher prevalence of autism spectrum disorder, which is known as ACD, more likely to be unemployed, less likely to obtain level 4 qualifications, that's working towards degree, and more likely to experience domestic violence, and finally lower rates of physical activity. So what we've looked at is it's not split it into two areas. We've just kind of mentioned it from there. So what we've got is another acronym that you might see around it, which is around GID and GIDS. So GIDS in this one was looking at access to gender identity development services. So in between 2010 and 2021, there was 14,646 referrals, including 300 nationally and 375 from West Midlands. This was taken from a report around which is called Gender Identity Development Services in 2021 referral, and that went into much more depth, looking at the annual increases of referrals coming in. As you can see from that, it's gone up over 1,500% within that. What it's also identified within that report was the average waiting time from a referral from first appointment is 2.5 years. Jordan? This slide in itself, there was so many different there was over sort of 20 different reports that could be identified just for this one slide of references around it. So this is around medical transition for trans adults. In England, there are 7 gender identity clinics. In England, 4 years is the average wait time from initial appointment, and based on information from December 2020 and February 2022 around London and the Devon Partnership Trust, they found that was the appointment time, which was around about 4 years. Slightly different to what we said in the previous slide as well, to be fair. 80% of trans people found the access to the GICs difficult to access, and that was taken from the National LGBT Survey in 2018, coming from the Government Equalities Office themselves. So some of the barriers of accessing the gender identity clinics: long wait times, the GP's lack of knowledge, which is already said a little bit earlier, that 30% of trans people in West Midlands said the GP didn't even know where to refer them, and that was from the same the same survey from the Government Equalities Office. Jordan. Thank you. Looking at mental health, no surprise with some of the things that have been identified that it has a huge impact on mental health of the community. So 70% of trans and non-binary adults have experienced depression or anxiety in the last 12 months. This was taken from another survey that was done in LGBT in Britain, which was commissioned by Stonewall and YouGov. 12% have attempted suicide in the last 12 months versus 2% non-trans LGBT adults, and 7%, comparing that to the 7% of general adult population. That was taken from another study that was done in 2016, which was called the Mental Health and Wellbeing in England, and that was from the Adult Psychiatry Morbidity Survey as well. So we've seen some of the access, some of the barriers that have been mentioned that are contributing to some of these outcomes that we've had here, and the predictors of poor mental health, which have been identified, was from on the right hand side is from the levels of depression, transgender people, and its predictors. So this was a big study that was done in 2018, which looks at the cycle from gender dysphoria, lower self-esteem, lack of wider social support, transphobic bullying, looking at your age group if you're younger, and looking at your sexuality based on gender, like you're registered female at birth as well, where they drill down into it. Next one, Jordan. Next, we tried to follow the themes as much as we could based on the health and wellbeing survey. So you might see a couple of changes in difference of structure. So from a health status, we had very limited data or intelligence on health status, but what we found was 33% of trans people self-reported having a disability versus 40% of cisgender LGBT people, and 19%, comparing that to 90% of working adults in the general population. This was taken from the National LGBT Survey, and that again was from a government report from the Equalities Office. The last one, which I was going to go to the bottom, was that in 2017 there were 178 trans people with HIV. Estimated prevalence in the trans population in England is 0.46 to 4.78 per 1,000, so which is similar to cisgender population. This was taken from a report done in 2021 around HIV prevalence and the HIV clinical outcomes of transgender and gender diverse people in England. Access to healthcare, again, this stat from here, there's about 40 different references that came out of it. So 70 to 80% of trans people rated their GP experiences as positive. This is actually echoed in quite a lot. I won't be able to kind of read off it from there, but I would encourage you in the references and at the end of this presentation to have a look at it as well. In Birmingham, 79% said that the GP had little or no knowledge of gender dysphoria. So again, engagement opportunity to work with the healthcare environment is going to be huge. That comes out of this, and that was done by this was identified by the Birmingham LGBT Centre in 2011 Out and About report, mapping LGBT lives in Birmingham. Jordan. So we're going into protect and detect behaviors and so on. What I'm going to do is, because of looking at some of the time that we've got within there, it's best summarized within the infographics that we've got. So Jordan, I'll be able to just skip to on there to that section, because it is very, very good in highlighting those things around it. So if we're looking at the first parts that I mentioned in there, if we could just go into the last two slides, it will just cover the last bits that we were talking about around sort of crime and hate crime. Jordan, next one. Yeah. So if we're looking at some key data that's come around it, around transphobic hate crimes have increased 789% between 2010 and 2021. 40% of trans people had a negative experience based on their gender identity when trying to access healthcare services. Jordan, next bit, please. So there is a huge amount of data that's come out within that, and it is one of the longer sort of profiles that we've actually done, considering that there was a limited amount of data that's on there. What I want to do is just pass it over to Tessa at this point, where we're able to just get some of your views on some of the information around the profiles that we've brought forward. Tessa.
Sorry, just talking to myself momentarily then. Thank you very much, Ricky, and thanks very much for the team and to our partners in producing the profiles, because I think done a really good summary there. So thank you. Right, so I'm hoping that everyone's got Menti up on their screens and they've got the code entered, that 41607622. If we can just stick the info in the chat again as we move on to the first question. So the first question is really quick. So how do you feel today? So you've got a slidey bar on your Mentimeter. So do you feel in a low mood? And then we scale up to see how people are feeling. And then you can just hit submit and we'll see how people on the call are feeling. Oh, pretty good. 7.6. You're happier than the group we had earlier this morning. Brilliant. So we're soon to be settling around the 7.88, and we can see in the bottom right there how many people are responding out of the group. I don't know how many people we've actually got on the call. Does anybody know? But we've got about 14 people responding on Mentimeter, so that's just brilliant. Thank you. Let's move on to the next one. Set 7.6. We have to remember that for the end. The next question. So we're asking some fairly personal questions here. If you don't want to tell us, you really don't have to, but just give us an idea of how old people are on the call. So we've got a little cluster in that 35 to 44, 45 to 54. Oh, quite well spread out, actually. Brilliant. So we've got quite a good age range there. That's lovely. Thanks. You're very quick on Mentimeter, this group. Brilliant. And how would you define your ethnicity? So this is a free text question, so you can just type in it's interesting, isn't it? Because when we think about those broad census categories that we so often get our information in, it doesn't match what we're seeing here, is it? Where people give you that really granular detail about how people view their own ethnicity. Brilliant. Thank you very much for sharing. You guys have been really open. Let's move on to the next question, which is around your religion. Okay, so we've got a majority of people without a religion that they identify with and a scattering amongst the rest of us. That's brilliant. Thank you. Let's move on to the next one. Lightning fast, this group on Menti. That's really helpful. Thank you. Next one. And if you can share the first part of your postcode, that gives us an indication of our reach for this particular. Okay. Okay, let's move on. Thank you. So now you get to rank some ideas, which ones you think are the most important. So we've got 5 issues that came out in the lesbian community profile. Which do you think is the most important health inequality for the lesbian community to focus on? So I'm requiring a bit more thought. I think people are. Anxiety and depression closely followed, and a quick catch up on substance misuse there too. Brilliant. Thank you. That's helpful. And the next one. And same question, but for the trans community, different issues that came up in the trans profile. Okay, so it's interesting to see these jumping around, aren't they, as people are selecting them. So equal top, we have the access to healthcare services and the mental health indicators, very closely followed by hate crime. That's really useful to have. Thank you. And the next one. So how in your organisation are you able to cascade this information into the trans and lesbian communities and with key stakeholders? We're looking for free text here. Great, so we've got quite a networked group here, which is really helpful, and people offering to cascade the information in various meetings and discussions that they're in and using their social media, which I think will be really helpful. Yes, and through our experts by experience groups, really important route there. And then opportunities to embed the key findings from the profiles into your line of work. So how can you use the information to help you make decisions in your line of work? Great, so we've got quite a variety there. So people involved in strategic work and co-production, working with experts by experience, but also feeding it into HR policy and practice, which is important as well as informing commissioning decisions. Health equity works. There's some really good opportunities there. Thank you. Okay. And in terms of our future engagement about these profiles, we're really interested in ideas that you have about what should the future engagement for the lesbian and trans profiles look like. So ideas will be gratefully received. Good to see them pop up on the screen. Yep, some great ideas there, and absolutely it would be great if we had local data, wouldn't it? That would be really fantastic, and to use all those opportunities that we talked about earlier on to engage with people. Brilliant, thank you. And what will success look like? How will we measure the success of these profiles? Absolutely. So we really want people to use them, and we really want to see some change, don't we? That's a perfect measure of success. Yep. And changes in the data. Yes, that's true. So do they generate a factor when they're referenced? So people going back to references and using them? And that feedback. Yes, but some nice practical things there about them being used, which is exactly what we want. Yeah, and a future for decision making and research. So really, really important. Okay, fantastic. Thank you. Okay, so at the beginning we asked about how you felt. How do you feel after the workshop? So how do we feel now at the end of the workshop? Brilliant. So we've sort of settled on that kind of 8, haven't we? 8 out of 10 looks about how we feel at the end. That's not bad after sitting and listening to a webinar for an hour. So thank you very much, everybody, for sticking with it and hearing us out. Just quickly, next steps. Ricky, did you want to just say a couple of words about next steps?
Yeah, so some of the things obviously that have been kind of highlighted is in terms of like, okay, there's no good these being on shelves and nothing getting done about it. What we've done is to commission out partner organizations. So the tenders are, I'm talking about this generically with all the profiles we've done. Either some have already been agreed with a partner, or the tenders are still live. For people to actually look at some of the findings within the profile and try to try to tackle some of the inequality that's been highlighted within there. And we're having a relationship with that over the next 12 months. We will be evaluating it. We're also going to be starting the next process of another 11 to 12 profiles that we're going to be doing in the next phase. So we're starting with, this is part of phase 1. Phase 2 is kicking off at the same time, but we're engaging with our partners to get sort of a pan Birmingham or a concentrated area of some of the activity in order to kind of address some of those inequalities as well. So we've done this bit, we've highlighted what the intelligence is. Now is our time to build up that our community engagement to try and tackle some of this, or come up with schemes, some innovation within it as well. So as you can see, as you've probably been aware over the last couple of years, it's a real huge attempt from public health in order to engage with communities as well, especially from a health perspective.
Thank you. That's really great. Okay, So we've got more of these launch events coming up over the next few days. So if you're interested in the other communities that we'll be talking about next week, then please feel free to join us. But at this point, I just wanted to say a big thank you to people for joining the webinar and your interest in the community health profiles. I really hope you're going to find them useful. Yeah, have a good look at the website and look at the resources there, and we'll upload this webinar as quickly as we can so that you can share it and encourage other people to see it as well. Thank you very much to the communities team for all the work putting this together and the programme overall. Thank you to Ricky for presenting today, and to partners from Bayswater as well for their work on producing profiles for us. Really helpful. Lovely. So thank you very much, everybody. We'll close there. Bye now.